Okay, good afternoon, everybody. Welcome. It is my great pleasure to introduce my friend and colleague Martin Ridderstråle. Martin, I've known Martin for a few years, and as you can see from both his qualifications and his background, he's a very innovative and perhaps a very plural kind of a personality. I mean, somebody with an MD, a PhD, and an MBA. And also, when you look at his the places he's worked in clinical medicine, he's worked in academia, hardcore academia in Lund University. He's worked in industry with the Novo Nordisk company in a senior position. He's worked at the Novo Nordisk Foundation, a philanthropy, also in a very senior position. So he's kind of had this fairly rounded, background, viewing diabetes from multiple angles. I mean, at a policy level and also from a grassroots level of how to improve care and where the trend is going. And I think it's been when I look at what he's done, he's a very curious thinker, and he's always figuring out what the next step is and how to prepare the world for it. And currently, I mean, he was recently at the Novo Nordisk Foundation, but very recently, about a few months ago, he shifted from the Novo Nordisk Foundation to the famous Steno Diabetes Center. He formerly was also there at Steno Center as vice president for translational medicine and for clinical sciences there. Currently Martin's focus is on implementing precision diabetes, a very important topic, and also using data-driven approaches to quality of care. And in addition to his work in Denmark, Martin has a very global background. I mean, I had the pleasure of working with Martin on what became the Copenhagen Declaration. We brought together over 50 experts from across the world, worked for almost a year to construct a kind of a vision for where diabetes research, prevention, and care needs to go, and how we need to pivot the changes in precision diabetes and the changes in technology, AI, etc. So pleasure to invite Martin to give his, I think it'll be a provocative talk, from inpatient to outpatient to on-demand care. So Martin, can you take it away?
Those were very kind words. When I introduce myself, sometimes I say I come from molecule to mouse, to man, to management, to markets, to then do this home run and go back to man again, which is, of course, has been a tremendous journey. Also means I know very little about the one. And I use that. I hope I can use that to sort of understand, like a librarian, understand and find the different books in the library. I haven't necessarily read them all, but I know where to find them. All right, so let's see if technology works with me. Yes. So I bring this all familiar picture up here to start with on the prevalence of diabetes, really to show that over the last 30 years or so, the problem is not in Caucasian land. The problem is in South Asia, Asia. And for me, that's really important, because if Caucasian land, if global North is going to develop, we need to work together in a true collaboration with global South, where the leapfrogging of healthcare is going to occur. Healthcare in global North occurs very incrementally, because there's such a legacy effect in our healthcare system. And it's not going to be possible to deploy such a system in the global South. So it's going to be really exciting to see how we together can deal with this problem. But I'll give you some examples of how we think at Steno Diabetes Center in this lecture. It's not rocket science, obviously. Healthy diet, physical activity, weight loss, smoking cessation, sleep, stress management, and some medication. And it actually works. This is now 10 years old data from patients with complex type 2 diabetes who are referred to Steno Diabetes Center for a 9-month program. for a 9-month program, what you see is ABC, A for A1C, B blood pressure, C cholesterol, and whether they are on target or not at baseline, and then after the 9 months. So you can see that the few patients that came with 3 factors in control remain in control, and those with even 0 controlled factors for ABC at baseline move up to have 1 or 2 or even 3 of these factors in control. This, of course, is what happens in most diabetes outpatient outfits. It also has had a tremendous effect. This is very recent data from Denmark on the years lost to diabetes, exemplified by a 50-year-old male, type 1 or type 2 in the blue diagrams, where a person with type 1 diabetes has gone from losing 12 to 5 years in the last 25 years, which I think is tremendous, and also the effect on type 2 diabetes, 7 to 5 years, and the equivalent data for females to the right. So it really works fairly well, and it's getting better. It started for Steno Diabetes Center's sake in 1932, or even 10 years earlier, because this guy, August Kohl, he got from the Toronto Insulin Committee the right to manufacture and sell insulin, originally in the Scandinavian countries, and founded what then became the company Novo Nordisk, together with August Kongstedt, who was another pharma guy, and Hans Christian Hagedorn, the H in NPH insulin, Hagedorn, who was a doctor. Incidentally, he was the doctor of the wife of August Kohl, Marie Kohl, who also was a physician scientist, but had diabetes. So that was sort of the start of both the company and of Steno Diabetes Center. This was located in Gentofte at Niels Stensens Vej in 1932, and Hans Christian Hagedorn, as a primary physician, he really felt bad for people with type 1 diabetes mostly. Now, 10 years in, being treated with insulin, but of course suffering from a lot of different complications, not least kidney disease. So all of these 5 floors were vacated by inpatients. Now, 80 years after the center was started, I came to Steno, and the first thing that I did, although it was not my idea, I was obliged to do it, was to close the last inpatient ward at Steno. So Hans Christian opened them, I closed them. Sort of a romantic story. There is something. Why? Because diabetes care during the course of those 80 years have developed into not inpatient, but an outpatient specialty. You still have to admit patients with diabetes, but not for diabetes in most cases. So we went from inpatient to outpatient. Now, 8 years on after that, everything is moving much faster. We're going to transition from outpatient to on-demand care. So that's what we're going to be talking a little bit about, the challenges and opportunities of such a transition. But again, I think it's an incremental one compared to what can go on. It's going to happen in Global South. The center is no longer in Gentofte, but Herlev, another part of Copenhagen. It's much bigger, much brighter, much more beautiful. It's the largest diabetes clinic in Scandinavia, 12,000 patients. I think we should pride ourselves for having the whole diabetes type 1 journey, from being born almost with diabetes, and I think our oldest patient with type 1 diabetes is 98 years old today. So that's our main task, and then that of complex type 2 diabetes, with 540 people working at the center. This is what it looks like inside. Doctor's office, physical activity, kitchen. This is actually I don't know if you have these, your podiatrists. It's a mat for evaluating your gait. So a whole lot of stuff like that is, of course, going on at the diabetes center. This is the upload station where the patients can upload their data from pumps, from sensors and or glucometers. And I'll get back to the upload station. That's a little bit of a cliffhanger. Danish healthcare system is, of course, a public healthcare system paid for by tax, free. Not everything is free. There's regulations on what medications you can and cannot use, stuff like that. But it is, in that sense, an equitable system. A really important thing about the Scandinavian countries, but Denmark not least, is the Central Person Registry, the CPR number. So when you're born, you get a number, and that number follows you from cradle to grave. And every time something happens to you in society, and there's a register around it, that number is used to register your data. That data can then be used by those who organize and deploy healthcare and or scientists. So a lot of epidemiology has come out of the Danish healthcare system.
And this CPR is for health-related issues or anything?
Anything.
So bank accounts,
From
you go to jail,
tax to from paying tax to going to school to anything.
Oh.
Yeah. So in that sense, I guess it's even more than just a healthcare provider and the data within the system. It is a country which is one system. Huge possibilities in using this data. Also regulated.
Everybody has access. Let's say you're a doctor, and I'm seeing Mark Hutchinson, and can I look at his medical history but I can also see other issues not related to health?
Yes and no. So some things that are health related, I can see whether he went to the pharmacy and when he went to the pharmacy and stuff like that. I can see all the other electronic medical records around
Related to health.
Okay. Yeah, so that's a huge advantage. The Steno Center is not alone. It has partner hospitals around in the surrounding area of the capital region of Denmark, which is, of course, a very small country, 6 million or so inhabitants. And there are 4 other Steno centers now in Denmark, supported by the Novo Nordisk Foundation. Public and owned and run by the public, but supported in a public-private partnership with the foundation. These 4 in Denmark, and then there's one in the Faroe Islands and one in Greenland. Very different geographies, very different conditions. But in the triangulation of things, it really makes sense. And the centers started out as working not so much together, but are aligning more and more, I think, to a more sort of a common care model. Both competition and collaboration, of course, in such a system. From the outset of the modern Steno Center, these 4 entities have been represented or around. They've had different names, but research, education, clinic, treatment, and then a specific prevention and health promotion unit. But it's really important that they all center around what goes on in the clinic. So the questions that arise there, the data that are generated there, are used by the different other entities. It's been a success story in many ways in terms of publications. These are data from the other centers as well. Some of you may remember the Steno 2 study, which was a seminal work on risk factor control in diabetes, in people with diabetes and risk. There was, before the Steno 2 study, a Steno study. It was on kidney disease. There is now an ongoing Steno 1 study. Why 1 after 2? Well, 2 stands for type 2 diabetes. And now the same kind of concept in type 1, doing everything we can and to see what effect that can have. Is going on. So that's going to be exciting in a couple of years. The vision around less diabetes, more life is one that is now in a new sort of a new strategy cycle. There's much more focus now on prevention and cure. And I think in the whole community of diabetes and in the cardiometabolic community, indeed, this dialogue is emerging as something which I personally find very interesting. So Venkat and Ram and I, we wrote this article a couple of years ago, Managing Type 2 Diabetes Needs Paradigm Change. And that came out of a discussion on a paradigm shift for cardiometabolic disease from management of disease to prevent complications to early detection and maybe even cure of cardiometabolic disease. Most people have not in the field thought about these diseases in that way. They thought about cancer in that way. You know, if you develop cancer, you don't want someone to manage your cancer. You want them to treat it and cure it. But for some reason in the cardiometabolic space, we've accepted that we should chase the disease and prevent complications rather than cure the disease itself. It might be naive, people say, because calcium is a hard mineral to break once it's formed in plaques around your body. But of course, if you want to cure it, in this case, you need to go early. So that is the point, early detection of deteriorating glucose homeostasis or atherosclerosis. So I think it's bold and ambitious and really important that we have this discussion. Within the discussion, so these are the risk sort of engines or algorithms you can use. There is also an ambition to be much more precise in the definition of risk, to be able to tell people, yes, there's an 80% risk in these 20% of people that something will happen, or there's an 80% chance nothing will happen in these 20%, for instance. In the current landscape, we in fact over-treat a lot and under-treat a lot in different parts of the spectrum. This was also written out in a JACC state-of-the-art review on personalization within cardiovascular disease. So why the change of healthcare at all? Guillermo and I, we talked about the situation in Atlanta this morning. So of course there is a need for some change would be beneficial in any system, global north or south. But there are sort of two narratives here. One I'm afraid of, and one I would like to be a part of. This is the demographic development in Denmark for the next 25 years or so. So the whole population is aging, and this is kind of frightening. In 2020, there were 4.5 person per older person in Denmark. In 2036, it's 2.5 person per elderly person to take care of them. So this is quite a scary scenario, the demographic shift. We're getting older, we're getting more sick, we have less people to care for us. Let's do something. Well, I don't really want to be a part of that system, quite honestly. I want to be a part of a system that says, yep.
Is the aging, can you go back?
Yep.
Is the aging of the population in Denmark the same all over Europe?
No, it's different. I mean, the demographic shift is the same, but the average age is different. So the other more positive narrative is that there is now so much technology, treatment, understanding of both disease and treatments and human beings that we should be able to do something exciting, which is better than we did before. That system I would like to be part of and really create. And boy, do we have the technology. We have so much technology and so many apps, they don't even fit into Guillermo's telephone. So that's sort of where we are today, at least. The from inpatient to outpatient journey required standardization for any medical specialty. Actually, in the 80s or so, standardization occurred, and it has done tremendously well, not least in cancer, but also for diabetes, where standardized and regular controls and screening for complications has been a success factor. Now we're trying to take a step back and see how little can we screen and how rarely or how seldom can we meet to be able to actually provide people with a service that can make them stay at home, at work, in schools, where they want to live their lives. So that's the opportunity to go from all of these regular meetings to another situation. The problem is, what is that situation? We set out, and this is now data from 2022, which is the upper line, the visits from January to December, number of visits for type 1 diabetes in this case. So we set out with the goal of reducing the visits to the outpatient clinic by 50% by 2027, 50% for these 7,000 people. We've actually reduced it by December last year to 30% now. So we're on our way. But what happens to quality of care when you do that? That's the whole risk. Well, to quality of care, the following has happened since 2022, which is the lower one. What you see is the target attainment, HbA1c below 53. We measure HbA1c in millimoles per mole. So that's the target. When I worked at Steno last time, it was 18%. This is for the same type, adult type 1 diabetics. For children, it's much better. It was 18%. And then in 2022, it was just below 30%. And for each year, you can see how it increases. It is now 38%. So from 18 to 38, that's tremendous development, right? And it continues during these 3 years to improve, despite the 30% decrease in physical meetings. But we're still afraid that something is going to happen later on. So we have to monitor the system. We have some proactive processes that we try to promote, and some semi-reactive mechanisms. And Steno Detector is one of them, allowing this on-demand healthcare. Because, of course, if something happens, then we should know about it, and we should be able to get a hold of the patient, and we have to be able to offer them to visit us at any time of day. Deferring them for a visit in 2 years and say, that's not going to work. So the trick is how to do this. So we get all of their data. The database is updated every night for most data, for some data a bit more rarely. And it's displayed on a dashboard for nurses and doctors to act upon. And this is the way it looks. I'm not going to go through it in details, but we triage the patients based on medical needs. And so that is the basis for then setting up different target limits. We get information on hospitalization and new diagnosis. And whenever a blood pressure or HbA1c cholesterol is measured anywhere, it comes into the system and pops up here. And then we flag different events to be able to cater to this intricate system. People are referred, and they see, the physician, the nurse, the podiatrist, and everything, to be able to lay out the plan for what's going to happen. We do meet them on a regular, but not so often basis. And there is this surveillance system. An example, and then we need to complement this with what we have called Steno Pool. Those of you who care for people with diabetes with devices know that every device manufacturer has their own software and their own little app and their own little web page. So when you have 15 different devices to keep track of as a healthcare provider, it becomes very messy. Here we pooled all of the data into one web page. So the stand I showed you previously, where they upload their data, is needed, but really it should be an online system for it not to be needed. And we also see if there's missing data from the patients through this system. So Steno Detector complemented by Steno Pool for capturing the data. And this is an example for how it would work. For glucose, time in range, time below range, time above range would be measured. And if someone moves from being not so often in time below range, but to a situation where 4% of time is spent below range. We'll call them up. If someone who is time in range decreases from that time in range by more than 50%, that's a huge shift. We'll call them up. That's a red alert. So that's going to be acted on immediately. And then we have yellow flags. Yellow flags are more subacute. They're more of an opportunity. These opportunities have been around all the time, of course, but we've only seen them every 3 months or every 6 months. Now we see them all the time, which means that for it not to be too daunting, with too many opportunities to act upon and stress, the healthcare professional out, we set the limits so we get just enough of opportunity. So this is one way of doing it. If someone is time below range more than 2%, it will be flagged as an opportunity. If someone who has a time in range more than 65% of the time, but decreases by more than 15%, or time in range dips below 65%, that's an opportunity. And so on and so forth for different other groups. And of course, we can tweak this to become a manageable situation. So this is just to say that it's reactive because we need to see the red flags. It's proactive because we can act on the opportunities without stressing out.
Can I ask a question? I'm a clinician who work in the downtown Atlanta. So I'm fascinated. So you have a computerized system to track all of this information. So how does the computerized system or the system that would tell you time in range if the patient is doing it? Everybody gets a CGM, I guess. So, and then how that information is picked up and transferred to the physician or to the system to bring the patient back.
Yeah.
So for the non-clinician, time in range is we would like it the time within range of good glucose control. So it looks like if you drop below what you were want, the system will call you. How is that identified?
Well, I told you I know very little. From a technical point of view, I couldn't answer you. There is, so we have an agreement with all the different CGM systems owners that we get the data as well. They feel that they own the data, right? But we have an agreement that they don't. And there's also been just now passed a law that they're actually not allowed to collect the data. The regions collect the data through their devices. They want to keep it in their cloud, but we get it into the system. We use Epic, by the way. So Detector and Steno is about to work a little bit more smoothly with Epic, which is the electronic health record system.
It's like in your clinic.
So is everything going to be like this? Virtual? No, luckily not. We have some systems in place I'm going to tell you about to keep ourselves close to patients and to keep the data meaningful. So it's not just quantitative bits somewhere that we act upon, but actually there is some quality. So we identify Mr. and Mrs. Guideline, Mr. and Mrs. Average, and Mr. and Mrs. Opportunity. So you have?
Mr. and Other.
I have access to all the data, in fact. So I'm in a very fortunate position. So I get the data for the patients who are coming this week to a clinic, the data from their last visit, when we took a decision that they were supposed to come this week. And we only see people who need it. So the data we see are a little bit worse than the average data of the whole center, because most patients are home, right? So you need to be aware of this. And then we can look at, so 200 patients, this clinic with complete data. How many are A, B, C, D? By the way, we've gone from, I might have told you, we've gone from A, B, C to D, D for kidney, and then E for eye, heart, and hepatic, and F for foot. So we're at A, B, C, D, F now. How many are A, B, C, D? 33% of the patients below 53 in A1C, 37% below 130, 59% below 80 millimeters of mercury blood pressure, LDL 55%, urinary albumin excretion 50%. That's quite good. But Mr. and Mrs. Guideline have a very small family, A, B, C, D. That's Mr. and Mrs. Guideline. Only 7 people, 3%, 7 people are at target for A, B, and C, and D. So the population and the people are not the same. Mr. and Mrs. Opportunity, who have no control over A, B, C, or D, nothing. They're a little bit bigger a group, 22. So this defines the common task for the physicians and nurses and dietitians for these 200 patients coming to us this week. Next week, we can look at what their data actually was, because that's important. The data we decided and took action on, the last visit data to give them this visit, did it improve? It did. If it did not improve, we need to discuss that. So it's a mechanism for, you could say, real-time quality work or data-driven quality of care development. And these are the data, the average data for their blood pressures and so on and so forth. And then we add the numbers, the guideline, ABCD controlled, non-ABCD controlled here, and over time fill out, the statistic to be able to focus on what is the theme for us now. In this month, for instance, blood pressure. What do the guidelines say? What are we measuring? How are we treating? How are you doing compared to me? And do we have the right processes? And then bring your cases on blood pressure in this case. So an ongoing dialogue to inform each other and develop care. Does it make sense? We can also use the data. So each dot here is a patient. We can also use the data to stratify the patients. In this case, 3 clusters of type 1 diabetes, 4 clusters, the known clusters for type 2 diabetes, SIRD, SID, MOD, MARD, and how our patients fare. It's actually quite interesting to do it for type 1 diabetes as well. They're very reproducible. And so you can find opportunities in patients that way. You can also use the data through what I call a Steno clinical insight. So this is where I or a group around me analyze data to come up with insights that I then bring to the clinicians for them to discuss surprises or insights from the data from their patients, not patients anywhere in the world, but their patients, which makes the data much more interesting. What you're looking at here is for each year, so for babies and for teenagers and for middle-aged and elderly, their average A1C cross-sectionally, which represents what happens to A1C over the course of a lifetime for type 1 diabetes. They start out well, and then puberty hits, and then they fare fairly well for the rest of their lives. These guys are 100% on pump, and these guys are 38% on pump, and AID use, as you use as well, is going up. This curve it looks like this for type 1 diabetes all over the planet. This curve used to be up here. It's now down here, but this task is still here. So what does a healthcare system do with a problem like this? Well, so and I call it the 14 to 24 problem. What do a healthcare system do? Well, let's divide the problem in 2 so we don't see it as much. And then we call one part of it pediatrics and the other part endocrinology. So, and then if they don't talk to each other, so this is what happens when you give 2 people responsibility. They each take 1% of the responsibility. And then on top of that, to solve it, let's create a transition clinic for the problem. And now you have 3 people taking responsibility. So I bring this to the clinicians. They knew about it, but now it's here, it's concrete. We can work together to be able to service a problem a patient population has. We have created a non-solutional context for this problem by dividing the problem. It's just interesting. And so these kinds of insights are I think, conducive for quality work.
But it works?
Huh?
You decrease the spike when you add this transition doctor?
These are data from last month.
Oh.
But what we're going to do here is actually to give this group, Steno 1 is working over here, by the way, and this group on a national basis, if everything works out, SGLT2. It's been shown by others that might work in that group, so that could be done. Okay, we also have a couple of more conceptual things I would want to tell you about. One is the EPOS model, and the other is the clinical sweet spot model. The EPOS model stands for evidence-based medicine, precision medicine, personalized medicine through objective measures, and personalized medicine through subjective measures, what you might call individualized medicine. Now, we wanted to come up with this concept because when it comes to precision medicine, we heard different people using the same words, but actually meaning different things. And then again, some people using different words actually meaning the same thing. And there's been a lot of misunderstanding, I think, in precision medicine, and as if it were equal to genomic medicine, where in fact you can stratify on any variable, genes included, and call it precision medicine. So the problem here with evidence-based medicine and the randomized clinical trial, which is golden standard, is that it's designed to be able to detect the least statistically significant difference, which means that you need a lot of people for a long time to be able to show something which might not be clinically relevant. It might be, but might not. And on the other hand, if you have people who fare well and less well, the effect on an average might be nothing. And so you can't use that treatment. Precision medicine, which basically is stratify on any parameter for prediction of treatment or prognosis, might be able to complement that. But it uses the same kind of statistics to be able to come up with an answer. You probably look like someone here or here. You probably look like someone here. When it comes to personalization, it's your data, it's your mutation, it's your glucose that we can tweak the treatment for, or it's you as a person, the more qualitative discussion. And that is where the clinical sweet spot model comes in. I'll tell you about it. In terms of trials, when you do a precision medicine trial, you do randomize, but you randomize between standard of care for everyone and stratification, and then deployment of different treatments. And you can actually put up a fairly ambitious goal. This treatment, this approach to either stratify or give everyone one size fits all, it has to mean something. It has to be 5 millimoles of HbA1c or 5 millimeters of mercury. Otherwise, I wouldn't recommend my patient to shift from something to something else. So it's a different and complementary approach. The poster child for a precision trial is the TriMaster study. I'm not going to go into it, but the one I showed you on the last slide is a little bit more simple than this. What they did was actually to show that some medications work better in some patients based on BMI and kidney function. But it was a very cumbersome trial. So I think we all need to be a part of developing the precision medicine trials into something which is clinically relevant. Now, the clinical sweet spot is a place where treatment works the best. I sometimes say that we need to identify the best and most preferred treatment. And then some people say, well, but the best treatment is the most preferred treatment. But that's not really the case. If you don't like injections, even if an injection is the best medicine, and prefer a pill, then that's the best and most preferred treatment, for instance. And the clinical sweet spot model is also addressing the fact that now there's so much data, so much quantitative data, and so much compute power that there is a risk that we focus only on those kinds of data and forget the qualitative data and the human being, basically. So we can identify what the patient needs. Medical professions do that, the medical needs on the one hand. On the other, it's important to find the sweet spot to inquire what the patient is good at. If you prescribe a 3 times daily pill to someone who is quite forgetful, that might not be the best solution, instead of an injection once a month, if that is the alternative. On the other hand, we also have to take care for what the patient can have or can afford in many situations to be able to be realistic. On the one hand, and on the other, what the patient wants. So these circles, this Venn diagram, will identify a couple of areas that I think are interesting to consider when going through an interview or a situation where communication is important to extract data. Between what the patient can expect and what the patient needs lies what I call the basic space, or the minimal viable care solution that can be worked out. Between what the patient needs and what the patient wants lies the clinical space, or the mission space, where you can work out a little bit more of an ambitious solution for a patient, or together with the patient. Between what the patient wants and what the patient is good at lies the passion space. Very important space. I'll get back to that. And then between what the patient is good at and can expect lies the opportunity space, or the realistic space. Once you then, with this data, approach the clinical sweet spot, you have to take care or beware, because there is a risk that you identify something which is affordable but not desirable on the one hand, and on the other, something which is desirable but not affordable. And on the other, something which is important from a medical point of view, but not realistic, or realistic, but not important. So this might also happen to your data. I also see this as a space of opportunity where we prepare and plow the field to be able to then plant the seed in the basic space and grow the plant, cultivate it in the mission space, and importantly, harvest in the passion space. Because if the patient is doing something he or she is good at for something she or he wants, and it succeeds in the passion space, there you get patient satisfaction, alignment with treatment or compliance, and then you can build upon that. If you think about it, you can actually take away the doctor and the patient, or the nurse and the patient, and put the student and teacher in the same situation. A teacher which finds out what the needs are through what the pupil is good at, and he or she will harvest in an area where they want to be. So this is a way, I think, to get conceptually closer to the individualization of medicine without going astray in the data jungle. I mean, if you think about it, this is the ADA, I think, recommendation graphic. It captures these different elements, but just in a little bit more of a perhaps a conceptual way. Last but not least, I wanted to come back to, in fact, to global North and South, where I started out. These are the people who took part of the first Global Diabetes Forum to come up with the Copenhagen Declaration. And I'm so humbled and grateful that I was a part of that, because it was a very structured and conscious way of getting these 50 or so people together. Equal distribution from global North and South, equal distribution men and women, co-chairmanship, and even preclinic and clinic, to be able to come up with these different recommendations for what the opportunities for global diabetes care is in a dialogue and discussion, which was not without friction, obviously, but it was a step towards that equity in health that I think we all strive for. Thank you very much.
Thank you, Martin. As always, a splendid talk, and we're open for questions. Mo, are there any hands there in the audience?
So a main problem in taking care of patients with diabetes here and many other disorders, chronic diseases, is fragmentation of care.
Yep.
Because with the system that you don't have that problem. That's right. I mean, in the way here, you come to the hospital, you're seen by the hospital, they send it to the primary care, never seen the endo, or never see the kidney doctor or the eye doctor. That's the main problem that we have.
Yeah.
It looks like your system will allow a more cohesive system to prevent this fragmentation of care.
Yeah, it's of course a really important question, and I can't say that fragmentation does not occur in a system like this, but the transparency of data and the different systems put in place to be able to see what other entities do make for a better situation to counter fragmentation. So we have a system in the EHR where we can see what the primary healthcare physician has done, when he did it and why. And the municipalities can couple onto that because they are also an important part of the care value chain. When it comes to the surveillance system, detector, and the monitoring of data, there's no limit to that. If you take a population sort of responsibility view on your data, you can go outside of diabetes and say this is not a person with diabetes, it's a person with a life, and there are obviously a lot of multi-comorbidities, and then you can look at that life. In fact, a computer scientist has done that. So he's looked in the Danish data for trajectories of different diagnoses. When this happened, what preceded it in terms of other diagnoses? And you can take that and put it on top of your data that you're monitoring on a daily basis to be able to understand where things happen that you need to or should do something about in terms of fragmentation. So it's an important topic, but we're not even 10% on the way to solve it, I think.
Okay, I'm sorry.
Yeah, I mean, anybody else with the hands wants to ask questions? I have a question, but I can wait for others.
I just wanted to clarify, were those data that you showed from the eye study?
No, just a couple.
Go ahead, Mika.
Yeah, my question really is, Martin, great talk. I mean, again, I think what you're presenting is clearly the direction of the future, where as the science evolves, we are going to become more and more personalized and more customized and very much more specific towards the different presentations of diabetes and its forms. And also, like you correctly pointed out, we should be seeking cure for diabetes rather than just management. These are two fantastic ideas. Often, when we present these two directions, one of the opposition that we hear is that this will destroy population health, or it'll move away from the concept of addressing disparity and equity. Is something that's often brought up. I mean, I have my own thoughts on it, but I'd like your thoughts on whether you see this as a tension or you see personalized medicine as an equalizer.
My personal opinion is that you need to treat people differently to treat them equally or to create equity. And so I see precision as a concept as a means to be able to do that. From a more public health point of view, I don't believe that there should be any, there's no conflict between applying one or the other. They're complementary. So I usually take the example, if we could shift 1 kilogram lower in weight, that would probably be measurable on a national basis in terms of this disease. But you could never measure the effect in the person who lost a kilogram. You can see the population. And you are allowed to do something like that if it doesn't cost anything, doesn't hurt anybody. So those are sort of the premises. If instead, from a precision point of view, you can point to the people who should lose not 1, but 16 kilograms of weight to be able to reap the benefits of weight loss. And not everyone needs to do that, of course, but just for the sake of argument, you could never measure that effect in the population, but you could measure it in the individual. So those are just complementary views. But what's your view, Venkat?
No, I think I completely agree with you. I think what you put it very, very well is that, by addressing the specific needs of each individual correctly, you are actually reducing disparities. That's my view. And like you said, the question really is, how do you organize it at a public health level, or how do you integrate personalized care with what happens out in the community? I think that's where it's more of integration, but I don't think they are in conflict, because equity is about ensuring that each individual is treated based on their needs.
Well, so funnily, my question was very similar to Venkat. So you sort of didn't really have the equity angle, but I think a lot about this is someone who's further downstream, right? Does more community level implementation, mostly in nutrition and physical activity, which, as we learn more and more, it's becoming clear that personalization is important there. But I really struggle with how do we marry broader community-based interventions for behavior change with the need for personalization, and trying to figure out how to make that fit together is just something I have difficulty wrapping my head around. And you sort of talked about it in the context of your answer to Venkat, but if you have additional things related to lifestyle change, I'd love to hear your thoughts.
Well, regarding physical activity, there is this view that the best physical activity for someone is the physical activity that actually gets done. I don't like that view. I respect it, I understand it, I accept it. But I would want to take it one step further, as you know, in terms of precision prescription based on pathophysiology and physiology. But that being said, that's sort of an academic view. You have to work with people, for people, and they will never do anything if they don't like it. That's why the clinical sweet spot model is so important to keep in mind.
Which I think is a beautiful model just for implementation as well, not just clinical.
In terms of community-based big programs, we started a program called REACT, with 2 parts: one, detect, and then to react on what you detect. It is an investigation in Denmark and Spain to find people by ultrasound, find out whether they have plaques. And it's an interesting one because it will show that about 30% of people at the age of 30 to 45 already have developed plaques. And then the question is, should you treat them aggressively early? And if you do that, when you use and model health economics data in Denmark for that generation, you will save millions if you do that. But it's interesting because it's also designed to be able to find the people. So there's an algorithm not to screen everybody, but then you have to find a generation young enough that it matters in terms of treatment, but old enough that it matters to them. Because young people don't, certainly not young men, they don't want to be screened for anything. They're not going to die. I mean, not tomorrow anyway. So there you have to work together in the concepts that you're alluding to, right? And that's the exciting thing. If that is going to work, it has to work on people wanting it to work.
I was very interested in the integration of the data for the funneling of the data and I don't remember the names, the Steno.
Detector.
Yeah, the pool and right. And I was wondering if patients themselves see that classification of the red or the yellow?
They do actually, because you saw this doctor's office picture. There's a big screen, so everyone is looking at the same screen. That's part of the sort of the concept. Most people are yellow. The triage is green, yellow, red. Most people are red or yellow.
Yeah.
In fact, very few type 1 diabetics are green. It depends on how you define it, obviously. The type 2s who are not red should not go to this center. So that's more of an agreement in the healthcare system. But you can, of course, tweak also the components of a triage. In this case, there's a medical triage, which is presented to you, and you can accept it. We would never send someone with a Charcot foot to be cared for by anyone, by ourselves, even though everything else looks good, for instance. Then there's a triage on IT competency, and there is a triage on psychosocial needs. And that triage is quite interesting because you get presented, now that's just rolling out now, you get presented to needs that you should cater for, needs that you can't cater for, needs that are not needs because they're not defined as needs by the patient in a process where we figure out what people consider needs. And then those three ways of triaging can be combined.
So would you say that physicians feel less overwhelmed because the data are more accessible, or do you think they're more overwhelmed because everybody has a big problem?
Yeah, that's a good, I mean, that's a really good, you and I talked a little bit about it to be able to avoid stress in the group of physicians and nurses. If you see so much, so that's a really important, I only think you can solve that by discussing it as a group. And this group defines their goals. These are our goals for our patients. They're realistic to them and to us. And that discussion, not overwhelm themselves, is important. I also think that the way of bringing data from the patients to the clinician, nurses and doctors, is important for them to be engaged and to take ownership and to help each other as a care team. So if you miss out on that, then the data can become very aggressive and provoke you in the way of working, because there's a lot of generation of data as well. It takes time to generate this data, so the more you can automate that, the better. But then they have to mean something. And so that's why we had these different components that I talked about.
Any questions online? No, if not, Martin, thank you very much.
Thank you.
Thank you.